Hello, I'm Matt Oster, a pediatric cardiologist at Children's Healthcare of Atlanta. I'm happy to present to you this presentation entitled Congenital Heart Disease Review, Follow the Blood. The hope is that by reviewing some of the most common and most serious congenital heart disease defects, that you'll get a better understanding of exactly what we're looking at in these defects and what are the ramifications long-term for children who have these variety of congenital heart defects. Before we start getting into the defects, though, it's first important to remember what is the normal circulation that we have. And this will be the framework for everything that we do today. So in the normal heart, as shown here, first, the heart receives blood that comes back from the rest of the body. Starts for the top half of the body from the superior vena cava. Blood comes back from the arms, the chest, the head. And from the inferior vena cava down here, blood comes back from the abdomen, the pelvis, and the legs. That blood all comes to the right atrium where it mixes together. And not shown here, but there is also a little bit of blood that comes back from the heart itself, from the coronaries. That blood all mixes together and goes through the tricuspid valve into the right ventricle. There, the right ventricle will pump the blood through the pulmonary valve out to the pulmonary artery, which then splits into the left pulmonary artery and the right pulmonary artery going to the lungs. There, blood is oxygenated and then will return to the heart via the pulmonary veins, both on the left side and on the right side. That blood empties into the left atrium and then passes through the mitral valve to go to the left ventricle. There, blood is pumped from the left ventricle out of the aorta through the aortic valve to go to the rest of the body, to the arms, the legs, the head, throughout the whole rest of the body. And then will eventually return back through the venous system, the superior vena cava and the inferior vena cava, to repeat the whole process. That is the normal circulation in a normal heart in the postnatal period. But for some of our defects, you get a better understanding if you know what's also happening during fetal circulation. So fetal circulation, let's start again. So we've got blood coming back from the top half of the body in the fetus through the superior vena cava going through the right atrium. And there's blood also coming via the inferior vena cava. But you'll notice here in this drawing that this blood is red. That is because the oxygenated blood in a fetus is coming via the placenta and then joins to the inferior vena cava to bring oxygenated blood to the heart. Remember, oxygenation in the fetal period happens via the placenta. It does not happen in the lungs. So some of this blood that comes through a vena cava, since it already has oxygen and doesn't need to go through the whole circuit to go to the lungs, a good part of this will just go directly across this atrial septum and into the left atrium. And this hole here is our foramen ovale. If you've seen kids postnatally have a patent foramen ovale, that just means that this hole stayed open. And that hole is supposed to be open in utero, and it tends to remain open for days to weeks to months after the child is born. And for about 10% of the population, it actually remains open throughout their lifetime. Some of this blood, though, will empty into the right atrium and mix with the superior vena cava blood, go through the tricuspid valve to the right ventricle, get pumped out of the right ventricle through the pulmonary valve into the pulmonary arteries. And again, we have kind of another opportunity for oxygenated blood to bypass the lungs. So here is our ductus arteriosus. Now, this figure is not completely accurate because in utero, the ductus arteriosus is quite large. In fact, it's about the size of your ascending aorta in utero. That's because a lot of blood is going to skip the lungs because it's already oxygenated and instead just go directly and join up the aorta to go to the rest of the body. As you know, postnatally, this usually closes in the first few days of life, and in some cases it can stay open and you have a patent ductus arteriosus. But some of the blood does go to the lungs and then comes back through the pulmonary veins and goes to the left atrium, to the left ventricle, and then is pumped out the aorta to go to the rest of the body, just like it is in the postnatal period. And then much of this blood will go to the body, and again, remember, oxygenation will happen down in the placenta and then come back and join the inferior vena cava. With that in mind, we will now move on to reviewing some of the specific defects. How can the circulation that I've shown you, how can it go wrong or be interrupted? All right, so all of these defects will not be labeled initially to give you a chance to try to figure out for yourself what is the problem here. And so we're going to follow the blood for each of these defects to figure out where is the problem that we are seeing. So start with blood coming in from the SVC and IVC of the right atrium, no problems. Goes to the right ventricle, goes to the pulmonary artery, all looks good so far. Comes back to the heart via the pulmonary veins, left atrium, left ventricle, aorta, everything's looking good. As you can see so far, everything here looks very similar to our normal heart that's in the bottom left of the slide, and that'll be on every slide. So blood is going to pump out the aorta to go to the body, and then we run into a problem. We have a narrowed aorta here. So this is going to be coarctation of the aorta. So in coarctation of the aorta, we have a narrowing of the aorta. It can actually be anywhere along the aorta, but this is the most typical spot, at the spot where the PDA had previously inserted. And what this means, or what the problem here is that the left ventricle is trying to pump blood out to the rest of the body, and it's fine going to the arms and legs, but it reaches a point of obstruction here, and blood cannot get down distally to the descending aorta and to the rest of the body. Blood will slowly get through there diastole, but it's not necessarily good pulsatile flow. So how do we find this? Because this is one of the most common critical congenital heart defects. And what do we do about it? Well, the first thing is that if it's a really, really severe coarctation, then the PDA, which is not shown here, but you saw in the prenatal one, will actually stay open and try to provide blood going from the pulmonary artery to the descending part of the aorta. It'll try to bypass this coarct and relieve some of the obstruction and allow blood to get out. And if that happens, though, if blood is going from the pulmonary artery across the PDA and down the aorta after the child's born, it's like, remember, that's completely normal before the child's born. But if that persists after the child's born because of a problem, then what will happen there is that the blood that is going to the bottom half of the body will have less oxygen than the blood that's going to the top half of the body. So for anyone who's familiar with critical congenital heart disease screening, this is the rationale behind looking for a greater than 3% oxygen difference in the pulse oximetry test between blood that's in the upper extremities versus blood that's in the lower extremities. While pulse oximetry screening, if you have a differential in the blood, can pick up some of the most severe cases of critical coarctation if the PDA is open, many cases are still missed. And why is that? And that is because in many cases of coarctation, or that PDA still goes through its natural process of closing. So, with that PDA open in utero, it's not a problem because remember that's oxygenated blood going, out to the rest of the body, even if it's coming from the pulmonary. But postnatally, if that closes, we've got a problem. We're not getting good blood going distally. And so what you will see there is a few things. So first, on physical exam, you'll see that the pulses in the legs are not quite as strong, or may even be completely absent compared to the pulses that are in the upper half of the body. Okay. Second, many of these babies, if there's no difference in oxygen saturation, they'll pass their pulse ox screening. They may not have a murmur or anything, and they could go home, but they're not feeding well, or they're just throwing up, vomiting, and that's because if not a lot of blood is getting to the gut is not happy and does not really tolerate having milk going into it and being asked to start absorbing all of this milk because it's not well perfused. In turn, this could eventually lead to just poor delivery of oxygen nutrients to the bottom half of the body, and the child could eventually present in shock. Once we do pick up coarctation of the aorta, though, we do need to relieve this obstruction. In babies, this is typically a surgical procedure. There are a variety of different surgical procedures to address this. It can be anything as simply as cutting out that narrowed portion and connecting the top and bottom part. Some people have tried to open up that area and then use one of these arteries called the subclavian artery and just bring it down and use kind of native artery tissue to augment this tube, that aorta going down. Other times you can use this other patch material. There are a variety of different ways to look at this. No matter what the variety of way that is used, there is always the possibility that things will tighten down again. We call that a recoart. So these kids do need to be monitored and observed. If they're diagnosed older, or if they have a recoart even after diagnosis in infancy, then later on they can go to the cardiac catheterization lab and have a catheter placed up into the aorta, and a balloon can be expanded inside to open that up. Then they remove the balloon. Or sometimes even a stent can be placed to prop that area open. We don't like to do that early on in the young babies just because there are many complications with it. That's usually reserved for older children. In the long term, we like to watch these kids for development of, as we said, the recoartation, for any long-term effects on the left and right ventricle, for any hypertension that could develop that's often present initially and then could develop over time, just looking at long-term outcomes of them. Long-term outcomes are generally excellent, but these people still do need to be observed. All right. Now we're going to move on to our next image. And let's follow the blood again. So we have blood in our SVC, IVC, coming up to the right atrium, goes through the tricuspid valve to the right ventricle, and there's an opening here. Okay, we've got an opening in the ventricles, and blood can go out the pulmonary arteries. We've got a PDA open. That's odd. I wonder why that's there. Blood goes to the lungs, comes back to the veins, left atrium, left ventricle, goes out the aorta, which looks rather small. And we'll go up to the head next, then go through. No, there is something here that's keeping blood from going from the ascending aorta across down to the descending aorta. And this is what we'll call an interrupted aortic arch. Think of this as a coarctation to the extreme. And interrupted arches can be anywhere again. Can be here, past the subclavian, as we said, could be between the carotid and subclavian, could be between the brachiocephalic and the left carotid, can be many different areas. Similar to a coarctation, though, these children need to have some way of getting blood distally down to their feet. So in these kids, the PDA will typically stay open because it's necessary in order to get some blood going down. If there's no way that blood's going down there, these kids will be deathly ill when they're born, or may not even make it to being born. The VSD, is often present, not always, but is often present in interrupted aortic arch, and that just allows for some blood flow to still get out and go distally here from the left ventricle going out. Surgery for these kids is pretty straightforward. We will go and, where this interrupted aortic arch is, just connect this part of the aorta down to this part of the aorta and then get rid of the PDA. And then the long-term follow-up for these children is very similar to those with coarctation of the aorta. Now we're getting into some of our more severe defects. So in this defect, we've got blood in the SVC, IVC, right atrium again. Okay. Blood's going down through the tricuspid valve, the right ventricle, all good. Out the pulmonary valve, pulmonary artery, goes to the lungs on both sides, comes back to the pulmonary vein, left atrium, and it's not really, goes through this mitral valve sometimes doesn't. It goes to a very, very, very small left ventricle. Some of this blood might get through a very, very small aorta up front, but a lot of the blood distally is going again across this PDA, across the pulmonary arteries, through the PDA, out the aorta. So this is a case of hypoplastic left heart syndrome. So let's review some of the key features of hypoplastic left heart syndrome. Where does the blood need to go for these children? So hypoplastic left heart syndrome takes on a few different varieties that are all kind of part of hypoplastic left heart syndrome. And the problem in hypoplastic left heart syndrome usually has to do with either the mitral valve or the aortic valve and when they happen. One or both of these will be either very stenotic, meaning very tight, not allowing a lot of blood flowing through them, or sometimes can be even atretic, where it is completely closed. There is no blood going through either of those. In the development of the human heart, we have a saying called no flow, no grow. In other words, blood to the developing heart and vessels is like fertilizer for a plant. You kind of need it in order to grow. So if we have a very stenotic or atretic mitral valve, not much blood's going to want to get in there, into that left ventricle. Similarly, if we have a very stenotic or atretic aortic valve, there's no real place for the blood that's in the left ventricle to go, so things back up and not a lot goes in there to begin with. So if there's not a lot of blood going in this left ventricle, then what we'll be left with is a very underdeveloped left ventricle. So where's the blood in this situation need to go? Well, as I said, in some cases there will be some blood going through the normal pathway, but that's going to be not nearly enough to sustain long term. So blood that comes to the left atrium will tend to go across the atrial septum to the right atrium. If we see that in utero on prenatal ultrasounds, we know that there's probably something wrong with the left ventricle. If blood's going across from the left side to the right side. So the blood that's oxygenated will come across into the right atrium and mix with that deoxygenated blood coming from the SVC and the IVC, and then it will all go into the right ventricle, go out the pulmonary artery, and then some will go to the lungs, and then some will go to the rest of the body. Okay? So this is a classic mixing lesion. So these children, when they're born, will have or should have low oxygen levels, if not immediately after birth, then shortly thereafter. Well, the oxygen levels can still be pretty darn close to normal, all depending on the amount of mixing that's going on. There have been kids with hypoplastic left heart syndrome who are born who have oxygen levels in the mid-90s. And that's pretty high, but it does happen. Usually they'll be in the low 90s or 80s, sometimes even lower. Again, it all depends on how much mixing is going on. If these kids are missed, then when they really get into trouble is when this PDA starts to close. All right? If that PDA starts to close and there's not enough blood going out to the aorta, then they will start to develop shock and have many of the same problems that we talked about with coarctation of the aorta. All right, let's move on to the next one. All right, following the blood, we've got blood coming from the SVC, the IVC, the right atrium, goes across the tricuspid valve. No, there's no blood going across the tricuspid valve here. That is because this child has tricuspid atresia. So in tricuspid atresia, this tricuspid valve is pretty much sealed shut. There's no flow going across here. So where does the blood go? All of the blood coming in the right atrium pretty much has to go across the atrial septum through that PFO, or if it's big, we'll call it ASD, into the left atrium, then to the left ventricle. And then from the left ventricle, blood will go out, usually both arteries somehow. So kids with tricuspid atresia typically have a VSD to allow blood to go out the aorta and to go out the pulmonary artery. Sometimes these arteries can be switched or have an unusual position, but what we're looking at when these children are born, shortly after they're born, is are they having enough blood going out the aorta and out the pulmonary artery? Blood that goes out the aorta will go to the rest of the body. Blood that goes out the pulmonary artery will go to the lungs and then come back and oxygenated. And then here we'll mix with all that blood coming back from the IVC and SVC crossing the atrial septum. So our next lesion, again, we've got blood coming via the SVC, blood coming via the IVC, goes into the right atrium. We're doing okay here. Blood goes through the tricuspid valve. All right, it's open here. We're in good shape. Goes to the right ventricle, then tries to go out the pulmonary artery. Uh-oh. We have an atretic pulmonary valve here. So this child has pulmonary atresia. And in this particular case, we have an intact ventricular septum. We'll talk later about what happens when you don't have an intact ventricular septum. These two defects do act a little bit differently. So where's the blood going to go now? It can't go out the aorta. So first of all, this right ventricle, I think it's a little misleading, this picture, because this right ventricle is often very small cavity. It's often very thick muscle around there, but it's often a very small cavity. Again, no flow, no grow. Blood can't get out here, it's not going to want to come in here. So this right ventricle is often pretty underdeveloped. the overall development of the right ventricle here, and then similarly in some of our other single ventricle defects that I showed you, a lot of it kind of depends on when we think the potential insult, if you will, during development happened. If it's really late, then the right ventricle may have been growing well, and then all of a sudden this valve became atretic, so you might have a decent right ventricle. And sometimes those kids, we will try to use the right ventricle. If it happens earlier along, you'll have a smaller right ventricle, and it might not be usable long term. I'll have to come up with other plans for how to get this child to survive with that heart, which we'll talk about forthcoming. Okay, so if blood can't get out the right ventricle, it doesn't want to go that pathway. Again, it needs to cross the atrial septum and go to the left atrium. There, that deoxygenated blood will mix with blood that came back from the lungs and has oxygen, go out through the mitral valve, left ventricle, out the aorta, and then from the aorta, we're going to figure out how we're going to get blood to the lungs, and that's when this PDA needs to be open. All right, so this PDA will be open, and blood will go, some will go to the rest of the body as it's supposed to, and then some will go through the PDA to get to the lungs to get oxygenated. So again, just like the hypoplastic left heart syndrome or tricuspid atresia kids that I showed, how these kids look will depend on the overall amount of mixing and how much blood's going to the lungs and how much blood's going to the rest of the body. These children are for certain ductal dependent. They need to have a way to get blood to the lungs, and it's going to go through this ductus. So hypoplastic left heart syndrome, tricuspid atresia, and pulmonary atresia with intact septum, kind of our classic single ventricle lesions, although there are others that I'm not going to go over in this talk. And some cases of pulmonary atresia with intact septum, depending on that size of the right ventricle, can go down a two ventricle pathway. But what does going down a single ventricle pathway mean? So I'm going to go over that right now. Okay. So the whole goal of going down what we call the single ventricle pathway is to allow a child to live as long as possible with the heart that they were born with. We cannot make a left ventricle grow bigger. Okay? We cannot make a right ventricle grow bigger. Transplant is certainly an option for many of these kids, and back before these surgeries were really optimized, for lack of a better term, some centers, their primary treatment for children who are born with single ventricle heart disease was to directly go and do a heart transplant. That is no longer the case. Now for these children, for parents who wish to proceed with treatment of the disease, which is by far the vast majority these days, we go down the single ventricle pathway. At certain parts, if there are problems with how the heart's doing, or if we don't think it's going to last well long term, there is always the possibility deviating from that tract and going down the transplant pathway. Long term, and for some of these, the heart and the body was not meant to be with a single ventricle. So long term, and hopefully, our goal is to get these people to adulthood and as late into adulthood as possible. Most children with single ventricular heart disease at some point in their life will need a transplant. The most important thing when they're born is to make sure that they have an adequate balance of blood flow to the lungs and to the systemic circulation, to the body. All right. If that is okay, then we have time. We can wait. And the tricuspid atresia that I showed you, those kids often have both vessels coming off the heart. There's an opening between the ventricles, so blood can get to both. Some of those kids don't need something right away because they are well balanced. Kids with hypoplastic left heart syndrome, as shown here, kind of our classic single ventricle lesion, they need something right away. Right? They are not getting good blood flow to both places. So what do we do? So first thing that we do is we make sure we're getting blood to the rest of the body. Okay, so blood to the rest of the body, we had that pulmonary artery coming out, and that pulmonary artery was fine. It was well developed. It can get blood going to where we want. But the most important thing is the aorta. And so the aorta, we need to augment that, and we will sacrifice blood going to the lungs, through the coming directly from the heart in order to make sure we have blood going to the rest of the body. So the first step, as you see here, is they'll create what is called a neo-aorta. So the surgeons will use whatever native aortic tissue that they have. Then they will take the main pulmonary artery, as much of the pulmonary as they can keep, and basically sew that to the aorta. As needed, they can add some other material to augment this and make it bigger. But the goal is that now we have one big outflow. Okay, inside behind these stitches here is one big tube coming out. So blood is going to, from the right ventricle, is going to go out the pulmonary valve into this neo-aorta, as we call it, and it'll go out the aorta to the rest of the body. If there is any blood coming forward through the left ventricle, that blood will likewise go out the aortic valve and into this neo-aorta and go out to the rest of the body. So all the blood in this scenario that is being pumped out of the heart, so the right ventricle, left ventricle, is going out this neo-aorta. Great. Well, now we need to get blood to the lungs somehow. So that PDA, we don't like to keep it open. We can give medicines to keep it open short term, but long term, those medicines have a lot of side effects. So we need to find a way to get blood to the lungs. And if we're in the operating room already, we'll do another operative procedure to get blood there. And so that is why we will put here a shunt. Okay, classically, this is called a BT shunt, named after Alfred Blalock and Helen Taussig. Alfred Blalock was a surgeon. Helen Taussig was a pediatric cardiologist who came up with the idea. But many people, you will also hear this called the BTT shunt, with the other T standing for Vivian Thomas, who was one of the lab technicians who really helped pioneer the surgery in the lab for Dr. Blalock. So this blood from the BTT shunt will take blood from, that's going out really kind of the proximal brachiocephalic artery and go down to the lungs. Okay? So blood cells that are pumped out of the body that go into the neo-aorta then have the choice of either going out the aorta to the rest of the body or going through the BT shunt to the lungs to get oxygenated. All that blood is going to come back, so the stuff that comes to the lungs will then come back with oxygen to the left atrium. All the blood goes to the body, will then come back to the IVC of the right atrium, and all that will mix and get pumped out again. So typically after surgery, these children will have oxygen saturations of about 75 to 85% is kind of our ideal. It's our goal of where we're trying to get them. And we do this surgery usually in about the first week of life. Once the child is stable, the child is detected prenatally or shortly after birth, they usually haven't had any major complications. We will stave those off, and we'll just take them to the OR when we have time. It's not an emergency, but we want to do it soon. If children are picked up late and have had some of the sequelae of being born with this already, we'll first help them recover from that, and then when they're in better shape, we will take them to the operating room and do this procedure. So this procedure is done typically in the first week of life to get adequate blood flow to the lungs and to the rest of the body. But there's an alternative procedure to this that some places will do, and that is, instead of doing a NORD with a BT shunt, do a NORD with a SANO. So these are very complex surgeries, and the way that the NORD SANO basically came is, this was actually one of the initial proposals, and just some surgeons were better with the BT shunt, and some surgeons were better with the SANO. A lot of this is surgeon dependent. So in the SANO, instead of doing a BT shunt to get blood to go from the proximal brachiocephalic to the pulmonary artery, we just make a tube to go from the right ventricle directly to the pulmonary arteries. And so we place that conduit. That involves cutting into the right ventricle and going into the pulmonary artery. So now if I'm a red blood cell and I come to the right atrium and I go to the right ventricle, from here I have the choice of either going out the aorta and then just going to the rest of the body, or going out the tube here from the right ventricle and directly to the pulmonary arteries. From there, it's the same thing. Blood goes to the rest of the body, goes to the lungs, comes back to the right atrium, and then is mixed and repeats the cycle. Which one is better? I cannot answer that question for you right now. How things are done and what determines what a child gets is typically surgeon preference and center preference. There are many people who have felt that the PT shunt is better and many people who feel that the Sano is better. The theoretical problems with the BT shunt is that blood comes out the aorta, and a lot of the blood going through the BT shunt is in diastole when the heart is in rest, and that blood then is going passive to the lungs. Well, that's the same time that blood is supposed to be going to the coronaries. So there's a fear and a concern that you are stealing blood from the coronaries during diastole in order to get the blood go to the lungs. It's a very valid concern. Okay? Secondly, these BT shunts can often clot. Right? If this BT shunt clots off, that is an emergency. Right? We've seen it happen. It used to be more frequent than it is now. We're better with our anticoagulation than we used to be. But if that BT shunt forms a clot, remember that is foreign material that we're putting in there, so it is definitely prone to clot. And it's a small tube, usually about 3.5 millimeters in diameter. Then if there is a clot in there, that is a true emergency. If we send a child home with that, if that clot's at home, you typically do not have enough time to get the child to the hospital to recover. So many people were just seeing poor outcomes with the BT shunt. So that's why they thought the Sano would be. Well, is the Sano better, or what's the problems with the Sano? Well, one of the big concerns with the Sano is that in order to get this conduit to go into the right ventricle, you have to cut a hole into the right ventricle. So that hole in the right ventricle, eventually we're going to take this conduit down, but we're left with a big scar in that right ventricle. And we're asking that right ventricle to be our systemic ventricle for as long as possible. We're told we're trying to get these kids to as late into adulthood as possible. But there was a fear that if we are cutting into that right ventricle, that we're going to, over time, make it not function as well as it otherwise would have if we had not cut into it. There was a huge study that enrolled kids from 2004 2008 called the Single Ventricle Reconstruction Trial, funded by the NIH, and took place about 15 centers in North America to answer this question. They enrolled over 500 kids, and the long story short is we still don't know what is better. In a nutshell, the results of that study showed that short term, the first few months of life, that the Sano kids had better survival, but that over time, long term, that survival advantage kind of diminished, and both of them have a variety of different complications. That study is actually still going on. We're still following the children. As of 2018, we're still following children who were enrolled in that study and who are now getting into adolescence. So that's why right now I can't tell you which one's best. There's no definitive answer. It really just comes down to what the surgeon and the center where the child is having the procedure done, what they prefer. Okay. Now that happens, shortly after birth. We've got some good flow going to the lungs and to the rest of the body, but again, long term, we're asking one ventricle to do the work of two here. Right? We're asking that single right ventricle, or in the case of Dreiche's or others, that single left ventricle, we're asking that ventricle to pump to both the lungs and to the heart. Sorry, to the lungs and to the rest of the body. So that works okay for a few months, but is not a good long-term solution. So we need another plan to try to get blood going to the lungs. So enter the Glenn. So at the Glenn procedure, what do? So first we take down that BT shunt or that Sano, whatever we had, we take that down. We're not going to need that anymore. And now we just have blood from the SVC. We hook up the SVC directly to the right pulmonary artery. And that is in continuity with the left. So everything coming back from the top half of the body will come down to the right pulmonary artery and go to the lungs. So now, blood coming back, we're going to follow the blood from the SVC, will go to the lungs. It'll go and get oxygenated, come back to the pulmonary veins, and then cross the atrial septum. Blood coming back from the IVC will come to the right atrium, mix with that blood that is now oxygenated, go to the right ventricle, go out this neo aorta, and then just go to the rest of the body. Does not need to go to the lungs again. Right? Stuff that goes to the top of the body will then go to the lungs when it comes back. Stuff that goes to the bottom half of the body will just come directly back to the heart via the IVC. All right, so what does this mean and why do we do it? So first of all, why don't we just do this as the first procedure? Why, bother with that whole first problem? Well, the reason is because the lungs, in the first few months of life, still has very high resistance. Remember, in utero, the lungs are filled with fluid. They are not getting a lot of blood. So shortly, after a child's born or in those first few months, you need some sort of actual active pumping system to get blood to go to the lungs. After the first few months of life, that starts to, the resistance in the lungs does come down. So usually at about 4 to 6 months of life, we will do this Glenn procedure. Now, the blood that's going to the SVC comes back passively here. So we need to have a low resistance in the lungs. That drops over the first few months. But blood is just going to drain passively, just like it normally would go to the heart, but is now going to the lung. In children who have problems with their lungs or who have lots of infections or whose resistance doesn't drop for whatever reason, they're going to struggle with the Glenn and may not proceed to it. But most kids are able to get to this stage. Now I'm calling this the Glenn. I should point out here that a classic Glenn on the initial Glenn procedure was just hooking up the SVC directly to the right pulmonary artery alone. So if you hear the term called bidirectional Glenn, which is what all of our Glens pretty much are now, that just means that we hook it up here and blood can go to the RPA and go across to the left pulmonary artery in addition to the right pulmonary artery. Okay, so classic Glenn, blood goes just to the right pulmonary artery. We transect here and nothing goes to the left. But in all of our cases now, we hook this up here and it's a bidirectional Glenn and can go both directions. Okay. So after the Glenn stage, kids' saturations are usually actually about 80 to 90%. Kids aren't necessarily active a whole lot, and you're still having a lot of your blood flow go to your head. So there's not as much going to your legs. That's why our sats can still actually be getting better than they were after the Norwood Xana. Some kids, as they get older, these sats will slowly start dropping because you're pumping more blood to your legs as that starts developing and catching up with your head. So to speak, your head does grow faster earlier and it's proportionally bigger earlier on. Secondly, they can develop problems with blood by even bypassing the circuit and have other collaterals and stuff, but we follow them long term. But eventually, we want to get people to this third stage, and this is the Fontan. So what do we do with the Fontan? Well, the Fontan, we just take the blood that's coming up the IVC, and we now connect that up to the pulmonary artery as well. So now all the blood coming back from the SVC and the IVC is going up to the pulmonary artery. So the only deoxygenated blood after this time that is not going to the lungs, or we hope is not going to the lungs, is just the blood coming back from the coronary arteries. That blood is still going to empty directly into the right atrium. So for these children, their SATs will usually be in the mid-90s. It'll never be 100%, because I said some of that blood coming from the coronary arteries and then dumping, through the coronary sinus into the right atrium is not going to go to the lungs. So blood that goes from IVC and SVC to the pulmonary arteries will go to the lungs, get oxygenated, come back via the pulmonary veins to the left atrium. We keep this septum open. They'll cross to the right atrium and come down to the right ventricle, and then go out through the aorta to the rest of the body. There are a few different modifications to the Fontan that you should just be aware of, and there's different things that you'll see. There are classically 3 types of Fontan. The first type that people did was they just hooked up the atrium here directly to the pulmonary artery. All right, didn't bother with a little conduit or anything like that. They just hooked this and brought it up and boom, hooked it up there. That caused lots of problems long term, specifically with arrhythmias and with the atrium getting really big. Second, for those who have kind of this tunnel or conduit going through, we have types that are called intracardiac, which means we kind of run that tunnel through or along the inside the wall of the atrium, or if extracardiac, where we just have kind of the conduit and tunnel go directly around the heart and it doesn't go inside the heart. Most these days are extracardiac, but you will still see some intracardiac. Again, that comes down to surgeon preference. And then also preference, some places will leave a little kind of pop off here. We call that a fenestration, okay? And, it's a Fontan fenestration. That pop off allows blood to skip kind of the Fontan circuit, a little bit of it, and go directly to the right atrium and go to the rest of the body. I mentioned that the pulmonary vascular bed has a higher resistance. Your body was developed to have a pump going to the lungs, and now we are asking blood to passively flow through there. And that doesn't always work perfectly. So we like sometimes to have a pop-off there. So if for whatever reason the pulmonary vascular resistance rises, blood can still get to the heart and get out to the body. We still want to have good cardiac output. It'll be at the sacrifice of oxygenation. Children of Fontan fenestration, their saturations will be lower if blood is going across that fenestration because it is bypassing. But from a purely physiologic, we're trying to get blood to the lungs and to the rest of the body standpoint, this works. Blood is going to flow past through the lungs, get oxygenated, and then it's going to go to the heart and go to the rest of the body. That solves our immediate problem that this child had when he was born with. All right, so when do we do this Fontan? That is a question that is still up for debate. Some people like to do them early, as early as about 18 months would kind of be early. Most places do them around 3 or 4 years of age. Some people are saying do them later on, wait till the saturations start dropping. I mentioned the Glenn saturations are usually kind of 80 to 90. Some people will say, well, wait till the oxygen saturations start getting further down to 70 and then go ahead and do it. Let them live with the Glenn as long as possible. While the Fontan does solve the problem of making sure we're getting blood to the lungs and to the rest of the body, this does introduce a whole host of other problems. So long-term, children with single ventricle heart disease can certainly have problems with their heart, from its function to obstruction to arrhythmias. A whole host of problems can occur. So we're following them very closely long-term for that. But beyond the heart, there are a number of other problems. Starting from the top, there's problems with the brain and neurodevelopment. How much of that is a common developmental pathway versus hypoxia versus surgical techniques versus medical treatments? All that's still being teased out. We just know that they typically are at higher risk of having problems. Some do spectacular and go on, be doctors, and no one would ever know they have issues. Some have a higher degree of issues. It's a spectrum. They can have problems with their lungs. As I mentioned, this flow to the lungs is not normal. Over time, they can have issues just with how the flow is going to the lungs, the resistance there. They can have this entity called plastic bronchitis, many different problems with the lungs. They can have problems kind of with their lymph drainage system, with their fat drainage system. Again, that goes to the venous system, and we're messing with that, and we're doing some surgeries which can interrupt that. There are many big problems with the liver and the intestines. So we now do routine screening for liver problems in children who have had a Fontan. Once they start reaching adolescence, we are sending them to the liver specialist to get ahead of the game, because we know that this blood that's going back to the IVC up to through the Fontan circuit, a lot of it kind of get backed up. It's going, first of all, against gravity usually, and it can back up in the liver, cause congestion, and cause changes in the liver, which can cause a number of problems. Similarly, that can cause problems and swelling and edema in the intestines, and they can lose a lot of important nutrients and lose protein as well. Protein losing enteropathy. There's also kidney problems, which we feel is probably less of backup, but sometimes earlier on for just poor perfusion, poor pumping to the kidneys. And there are a number of other issues. So the single ventricle pathway, the great news about it is that it does allow these children who 30, 40 years ago, we did not have any good surgical option available, it allows them to live. And many of these kids are living into adulthood, and there are many adults walking around who have had a Fontan done, and you would not know it except for the scar in their chest. There are many others who do have problems. It's a wide spectrum, and so we need to follow them all closely as they grow long term. Okay, so for those who would like to take a break, now is a good time. This concludes part 1, going over some of the normals and the single ventricles and their treatment. Next, we will move on to some of the other most common and critical lesions and that you may encounter, and what are the options for children with those defects.
So now we're going to move on to the second half of the presentation of Follow the Blood. Before we do that, I just wanted to review again the normal circulation, just to refresh your memory if you haven't been following along with some of the normal stuff on the lower left. But remember, following the blood, we have blood coming from the SVC and the IVC to the right atrium, goes through the tricuspid valve to the right ventricle, out the right ventricle through the pulmonary valve to the pulmonary artery, goes through the left and the right pulmonary arteries to the lungs where it gets oxygenated, comes back through the pulmonary veins on both sides to the left atrium, through the mitral valve to the left ventricle, and then is pumped from the left ventricle through the aortic valve into the aorta, where blood then goes to the rest of the body and then returns to repeat the cycle. In utero, that's a little bit different. Blood also comes from the SVC and the IVC, except remember, blood in utero receives oxygen via the placenta, and so blood is coming from the umbilical vein that connects with the inferior vena cava and goes to the right atrium. Much of this blood is directed across the foramen valley into the left atrium. Some blood goes to the right atrium. The blood that is in the right atrium from the SVC and a little bit from the IVC goes also to the right ventricle through the tricuspid valve, out the pulmonary valve to the pulmonary artery. But then again here, a large part bypasses the lungs and goes through the ductus arteriosus into the aorta. Some does go to the lungs and comes back via the veins, the pulmonary veins, to the left atrium. Then goes through the mitral valve to the left ventricle, out the aortic valve, through the aorta, and then to the rest of the body. And then some of this blood goes via the umbilical artery to the placenta to get oxygen. Okay. So we have already talked a lot about the different single ventricles. Now let's talk about some of our other critical defects. Okay, so let's follow the blood in this one. Blood's coming from the SVC, IVC to the right atrium, then goes to the right ventricle. There's an opening here. It's a little ventricular septal defect here. So some blood's going to go across to the aorta. And some part of the aorta is kind of over the right ventricle. And so some of the blood also is going to go to this pulmonary artery, although it's very tight and narrow. And blood will go to the lungs, come back to the veins, left atrium, left ventricle, and out the rest of the body. So what is this defect? This is tetralogy of Fallot. Now, classically, people have described tetralogy of Fallot as 4 defects. And so when you're looking for it, you're looking to see, are there 4 things? So those 4 things are, and I mentioned already, the ventricular septal defect. That's an opening within the ventricular wall between the right ventricle and left ventricle. There is an overriding aorta. What does that mean? That means part of this aorta is riding over the right ventricle. It's not all over the left ventricle. Part of it's over the right ventricle. There is pulmonary stenosis, which means obstruction to flow going out the pulmonary artery. And not clearly shown here, but there is right ventricular hypertrophy. So this right ventricle, that muscle is much thicker than it usually is. So those are the 4 things that we classically think of for tetralogy of Fallot. But in actuality, there's really only one defect. And that defect is the VSD. So what happens? So what we have is anterior malalignment of the ventricular septum. That's a mouthful. What do we mean when we say that? Well, in the heart, think of the right side as anterior and over here as posterior. This is the membranous portion of the ventricular septum. Down here is always the muscular portion. So what we say is that this part came forward. Okay, so when that part comes forward, what does that leave us with? Well, obviously, first and most clearly, when this part comes forward, there's a defect in the ventricular septum, so a ventricular septal defect. That's the hole right here. Okay. Second, the aorta follows that membranous septum. So when this comes forward, the aorta comes forward. And when the aorta comes forward and it's over the right ventricle, that gives us our overriding aorta. Great. Next, as we have this coming forward, though, there's only so much space in the heart for things to develop. And so this outflow from the right ventricle going to the pulmonary arteries is much narrower than it typically is. And so as that is narrower, not a lot of blood's going to want to go through there. And remember we said in our earlier portion, no flow, no grow. If not as much blood is going through there, this whole area is going to be small and stenotic. And it's not just the pulmonary valve. So the pulmonary valve is often small or dysplastic or doesn't form right, but there's often multiple levels of stenosis from underneath the valve to at the level of the valve to above the valve in the pulmonary artery. And then fourth, right ventricular hypertrophy. How do we get that? Well, the main reason we think we see the right ventricular hypertrophy is that this right ventricle, while it was designed and is meant to see the resistance of the lungs, just pump to the lungs, is actually seeing the resistance of the body and the rest of the body. And that is a much higher resistance, much higher pressure system because it has a much higher resistance. So the right ventricle needs to get strong. It's like it's working out all the time and building the muscle. So that right ventricle is getting strong to be able to pump out. And so we end up with our right ventricular hypertrophy. Okay? So what do we do here for this procedure? Well, first, when the children are born, we need to make sure, just like in the single ventricle kids, that we have an adequate amount of blood going to the lungs and to the rest of the body. And a lot of that will depend on just how much flow, we have going out that pulmonary artery. How tight is it? These kids, will often present with a murmur, but sometimes not. That can be missed. And so if they're not detected prenatally through prenatal ultrasound or postnatally because of a murmur, then we can sometimes pick them up via pulse oximetry in their critical congenital heart disease screening because of that blood from the right ventricle that's going out the aorta will be deoxygenated blood. We'll have it, so your net blood level in the aorta will be lower. So first we need to see whether we think there's adequate blood flow going to the lungs. If there isn't, then we'll try to secure that there's enough blood flow. Okay, so for that blood flow, we'll use often, if the PVA is there, we can put a stent in it and open it up. If not, we can do a BT shunt like we do in the part of the single ventricle series, but do just a BT shunt to get blood going there. But eventually, we're going to want to do surgery in these kids. And before I get to the surgery, I do want to mention a moment in case you ever heard of TET spells. And what exactly does a TET spell mean? Well, for TET spells, it is a situation where the ratio of blood going to the lungs and to the rest of the body is greatly altered, such that now, all of a sudden, for whatever reason, there's a lot less blood going to the rest of the lungs. And this can happen in a variety of situations, but usually either there's some clamping down of muscle underneath here that's obstructing flow, or there's some reason why the resistance in the lungs has acutely gone much higher. For whatever reason, if that happens, even more and more blood is going to say, I'm not going to the lungs, I'm going to the rest of the body. And that's going to cause an acute drop in oxygen saturations. That'll lead to the children being very upset, or it can also just lead to some sort of change in mental status if the brain is not getting enough oxygen, kind of be dazed and confused. Older kids you've heard of maybe of kids squatting who have tetralogy flow. That's older kids who are trying to do a couple of things by squatting. One, increase the resistance in the systemic so that even though the resistance in the lungs may be going up, if the resistance in the rest of the body also goes up, blood will still want to go to the lungs. And then secondly, it helps get all that blood that's in the legs to return to the heart so that more and more can start going to the lungs and getting oxygen. I mentioned, the goal is to try to get enough blood going to the lungs and to the rest of the body. The BT shunt that I've talked about a couple of times, it was invented for expressly the purpose of treating children with tetralogy Fallot. That BT shunt, which goes from brachiocephalic on the right to the pulmonary artery, was created to help initially children with tetralogy Fallot. This is before the era of open heart surgery. It was started at Johns Hopkins, and I would highly recommend for anyone who wants to learn more about this and the story behind it to watch the movie Something the Lord Made. It's a wonderful movie for two purposes. One, it tells the story of how some pioneers in the field of pediatric cardiology and cardiac surgery thought outside the box and thought there has to be a way to get blood flow to the lungs for these children with tetralogy Fallot, and so came up with and instituted that shunt. But secondly, it's a great civil rights story, and it's a story about Vivian Thomas, the African-American lab technician who really came up with the mechanics of this and tested it in dogs in the lab, and actually was in the OR telling Dr. Blaylock what to do and how to do it, walking him through it, but never really got the credit for it until many, many years later. So I highly recommend that movie. It is available on HBO. It's an HBO movie, and it's called Something the Lord Made. Okay, but what do we do these days long-term for these children? Instead of doing the BT shunt, we do a procedure when they're usually, again, about 4 to 6 months of age, basically because we want them bigger. And you do a couple of things. First, close this VSD. Okay, so that VSD is closed to, they put a patch material here so that now all this blood in the right ventricle can't go across to the aorta. That's going to allow the child to have normal saturations. But then secondly, we need to relieve some of this stenosis going out to the pulmonary valve. So they'll typically do kind of open up a patch from the pulmonary artery down to the RV, and it's usually like a diamond-shaped patch. I apologize for my poor marker skills here with the mouse. But it's a patch to really open up that outflow tract so more blood can get through. Depending on the pulmonary valve, maybe about 10% of kids can use their native pulmonary valve. Many kids, their pulmonary valve will not be big enough for us to use, and so we'll actually just sacrifice that pulmonary valve and cut through it to make a big enough opening. So what we're left with, though, is that blood in the right ventricle can get out of the right ventricle to the pulmonary artery, and it can go to the lungs, but a lot of it, if we cut through that valve, will fall back. It'll come back and go into the right ventricle. We call that free regurgitation or free pulmonary insufficiency. Over time, that has a number of effects on the right ventricle. Namely, it's going to cause that right ventricle to start getting bigger and bigger and bigger. So what we need to do is basically put in a pulmonary valve in these children. We like to wait as long as possible, and mainly until they are adult size, because the valve is not going to grow with the child. So we don't put a valve in infancy because we know that that valve is not going to last long because children are growing and developing pretty fast. But we like to wait until they get to a size where we can put in a valve that's going to last them as long as possible. And then if we have to change it, it's due to problems with the valve itself and not just problems due to the child getting too big and the valve being too small. We can do that procedure. Traditionally, it has been done means another surgery, but these days there are many kids who are good candidates for us to do that in the cath lab, where we put a catheter up through femoral vein, go to the right atrium, through the right ventricle, and we can deploy a valve implanted on a stent into that pulmonary artery and it can work pretty well. Long term for any of these children, what happens even after we've done their first surgery and then their second? So again, there can be many problems along the way, and we will address that. The biggest things that we're looking at long term are arrhythmias and function of that right ventricle. Again, we're cutting into that right ventricle. Ventricles do not like to be cut into. There is a scar there. It can mess with their function long term. And then there can also be often arrhythmias, typically because, again, we've cut into that ventricle. There are pathways running through there, and that can cause some issues long term. But overall, kids with tetralogy of Fallot, while they have some of the same risks as some of the single ventricle kids, such as neurodevelopment, it's a spectrum, but many kids with tetralogy of Fallot are actually doing fantastically well and go into adulthood and never need another procedure in adulthood. Some go on to win Olympic gold medals in snowboarding, such as Shaun White, who had tetralogy of Fallot. Some go on to lead perfectly normal lives, and you would never know there's any problem unless you saw the scar on their chest. So it's a spectrum, but many of the kids are doing wonderful with this, and it's a true success story for the field. Okay, moving on to our next defect, following the blood. All right, we've seen a variation of this before. We have blood coming down the SVC of the right atrium, IVC of the right atrium, through the tricuspid valve, right ventricle, tries to go to the pulmonary artery, but it is closed. All right, but we've got a big opening here. So this child is going to be pulmonary atresia again, like we saw earlier, but this time with a ventricular septal defect. These kids act a little bit differently than the pulmonary atresia with intact ventricular septum. All right, we think that this often happens earlier in the process. And we've got this opening. This pulmonary artery is often very diminutive and often does not form properly. But not shown here, that is often the case in these kids, is, your body does have the capability to create a lot of vessels when it needs to. So many kids with pulmonary atresia with ventricular septal defect will have what we call a lot of collaterals, or if you've heard the term MAPCAs, that's major aortopulmonary collateral arteries. All right, so you'll often see pulmonary atresia with VSD with MAPCAs. So the major aortopulmonary collateral arteries are basically arteries that are running from various parts of the aorta to the lungs and to different arteries that are in the lungs and providing oxygen there. So some of these kids, when they're born, their oxygen level will usually overall be a little bit on the low side, usually high 80s, low 90s, depending on how much collateralization they have. They can be as low as 60s and 70s. But if you remember, our goal, our immediate goal, is to make sure that there's adequate blood flow to the pulmonary arteries and to the rest of the body. So are we getting enough blood to the lungs, and are we getting enough blood to the rest of the body? And so for some of these kids, they've figured it out. Their body, has had enough collateralization so that when they're born, they can get blood where it needs to go. There are some people who are 50s, 60s, and beyond who were born with this, who have never had a thing done to them because their bodies were able to get it right, or I shouldn't say get it right, but get it usable. They would get enough blood going to the lungs and the rest of the body. Long term, what we would like to do, if we can, and not every child is a candidate for this though, is to try though to bring all those collaterals in and what we call unifocalize them. So get them all to have kind of one focus to go from the heart to the pulmonary arteries. And when we, we'll have that happen. If we do the surgery, it'll be a lot kind of like what we saw with the tetralogy of Fallot, that we'll try to close the VSD here, and then we will try to get all those arteries to come into this pulmonary artery. And sometimes we'll do a conduit that goes from the right ventricle to the pulmonary artery if this tissue, the pulmonary tissue is not well developed, which often it isn't, have a conduit to go to the right ventricle to kind of the confluence of the pulmonary arteries and bring all those other collaterals in. It is a very tedious surgery. It is a very complex surgery. And as I said, not all kids are good candidates for it. So these are really on a case-by-case basis. Okay. Next defect. So following the blood, we've got blood in the SVC, IVC of the right atrium, goes through the tricuspid valve to the right ventricle. And here in the right ventricle, blood can go up the pulmonary artery, or it can go out the aorta here. And that aorta is well over the right ventricle. So these kids we call double outlet right ventricle, or DORV, if you've heard that term tossed around. So double outlet right ventricle is exactly what it sounds like. We have both the pulmonary artery and the aorta coming off the right ventricle. Now, in the schematic shown here, these vessels are what we call normally related, that the pulmonary is coming off anteriorly and the aorta is still coming off posteriorly. How is this different from tetralogy flow? Well, a lot of times, depending on how things look, we'll describe the DORVs as sometimes as a TET-like DORV, because there is very similar tetralogy flow. And in a TET-like DORV, you have the situations we've seen here where that aorta is coming forward. And a lot of times this pulmonary artery can be pretty narrowed because there's not a lot of growth here. We will treat these kids similar to how we treat those with tetralogy flow. We will close that VSD and we'll try to come up with a opening or patch to open up the outflow going from the right ventricle to the pulmonary artery to get good flow going to the lungs. Okay. But you may also see situations though where these arteries are reversed, or we call malposed. You may see transposition of the great arteries, DORV with transposition of great arteries. Proper term would be malposed great vessels if they're coming off the same ventricle, but regardless, in those kids, we will treat them similar to how we will kids with DTGA if we can, if the ventricles allow it, depending on how well they're developed. And I'll talk about DTGA in just a little bit. All right, following the blood here, SVC, IVC to the right atrium, goes to the tricuspid valve to the right ventricle, out the right ventricle to the aorta? That's not right. All right. Well, let's try the left side. Pulmonary blood flow, pulmonary veins, left atrium, left ventricle, out to the pulmonary artery, and then pulmonary veins, left atrium, left ventricle. That's not right. So what we have here is detransposition of great arteries. When people say transposition of great arteries, this is the one they typically mean. And there's D and then there's L. I'll talk about L in a bit, but what we mean when we say D and L is the relationship of the ventricles and how the ventricles develop. We don't call the left ventricle because it's on the left. We don't call the right ventricle because it's on the right. Those are kind of what they become known as. But we define the left ventricle and the right ventricle based on their appearance and how they look. Remember, they're designed to pump differently. The right ventricle was designed to pump to the lungs. The left ventricle was designed to pump to the rest of the body. So they're going to have a few different characteristics developmentally. So the characteristics of the right ventricle are, one, it's going to have a tricuspid valve with it. So the valve goes with the ventricle. Second, it's going to have often a moderator band here, going across. And then third, it's going to have a little bit more coarse appearance of its musculature. The musculature is not going to be as well developed, so to speak. The left ventricle, on the other hand, is going to have the mitral valve going with it. It's not going to have that moderator band. And it's often going to be much more smooth-walled, okay? Because there are many instances when the left ventricle could be on the right and the right ventricle be on the left in many different types of diseases that we look at. So when we're calling a ventricle, a left or right ventricle. If we call it a left ventricle, it's not because it's on the left, it's because it has those characteristics of having a mitral valve and a smooth wall. Similarly, we're not calling a right ventricle because it's on the right, although usually that's where it is. We're calling it a right ventricle because it's got the tricuspid valve, that moderator band going across it, and those trabeculations that I talked about. Okay. Back to talking specifically, though, about what all this means for DTGA. Well, what we have here now is instead of circulation being in series of blood going right ventricle, lungs, then left ventricle, body, we've got two circulations in parallel. Okay, we've got right ventricle, right atrium, right ventricle, aorta, then back to right atrium, right ventricle, aorta. Similarly, on the other side, left atrium, left ventricle, pulmonary arteries, left atrium, left ventricle, pulmonary arteries. All right. Now, we're getting better about picking this up prenatally because now in prenatal ultrasounds, it is part of the certification to be able to recognize which vessel is coming off which ventricle. That used to not be the case. But we do also pick up in many of these with pulse oximetry screening because symptomatically, as long as that PDA is open and if there's enough mixing, either at the atrial level, ventricular level, or enough blood coming across the PDA to allow mixing, these kids will look pretty good, but their saturations will usually not be completely normal. So they'll have some low saturations because there needs to be some mixing somewhere to get enough oxygenated blood to the rest of the body and enough of the deoxygenated blood to the lungs so it can go get oxygen. Okay, so we have, this situation where the child's born and we need to get, again, balance of blood flow to the lungs and to the rest of the body. In the immediate term, we're okay if the kids are SATs in their 70s or 80s while we're buying some time to get them ready for surgery. But if they're not ready for surgery or if they are critically ill, we can do a procedure to try to help with that mixing. And so what that mixing is if this atrial septum is too small and there's not enough blood that can go across, we will actually do a procedure. It's called a Rashkin procedure, where we can insert a catheter through the femoral vein, run it up to the right atrium, run it across, however small this hole is in the atrial septum, put it in the left atrium, and then inflate a balloon. And inflate usually means with saline. And inflate a balloon and then pull back that balloon really hard to essentially rip a hole into the atrial septum. That's called a Rashkin procedure. It's kind of scary to watch. There can have complications, as you can imagine, if you pull too hard and pull the atrium down into the IVC. But when done right, it works. You can make a nice big hole there and allow some good mixing of flow there. Okay. Next, though, we need to figure out a way to get the deoxygenated blood to the lungs and the oxygenated blood to the rest of the body. All right, follow me here, and I'm going to try my best to draw something here, and I apologize if this does not go as well as I would like, but we're going to do our best. So, traditionally, the initial surgeries starting mainly in the 60s and the 70s were the mustard and the senning. And what do the mustard and the senning do? So the mustard and the senning really try to take blood from the SVC and the IVC and get them over to the pulmonary arteries. All right, so imagine if you will take blood here through the SVC, bring it over this way. Take blood from the IVC, bring it over this way. Okay, both going here. And if you will, we'll imagine that this blood flow coming from these two areas, it's described as kind of a pair of pants. So what we have here is we have one pant leg coming from the IVC, and then blood is directed through that part of the pant leg to the confluence, then goes into the left ventricle. And one part of the pant leg goes from the IVC up through this left pant leg, and then also joins up and goes to the left ventricle. So now we have deoxygenated blood from the right atrium, from the SVC and the IVC, being directed through what we call these baffles. Those drawings that I had, or we call them the baffles, will be directed through the mitral valve into the left ventricle. From there, that blood will go to the left ventricle to the pulmonary arteries, and then the blood will get oxygenated in the lungs, come back through the pulmonary veins. Then when it gets into the left atrium, it's blocked from going through the mitral valve. Those baffles are sewed in a way that the only blood that can get through that mitral valve is going through those pants coming from the SVC and the IVC. So the blood from the left atrium will cross the atrial septum, then go into the right atrium, and then it'll go through the open tricuspid valve into the right ventricle, and we now have oxygenated blood in that right ventricle, out through the aorta to the rest of the body. So we have solved our problem of getting adequate blood flow to the lungs and adequate blood flow to the rest of the body. And in fact, we're getting, all of our IVC and SVC blood to go to the lungs, which is great. And it's got a pump to do it. We're using the LV to get it there. That's more than adequate. And then we've got that oxygenated blood coming back, and it's going into a ventricle and being pumped out to the rest of the body. Great. So we've got a really good, efficient, and well-working system here to get blood where it needs to go. So what's the problem? Couple of problems. Number one, I've mentioned a couple of times today that, remember, the right ventricle was not designed to pump to the systemic circulation lifelong. Over time, that can cause problems. The right ventricle doesn't work as well. The tricuspid valve can start leaking a whole lot. So people can basically get heart failure from that right ventricle just not being able to last as long as we would like it to last. Second, those baffles that I drew going into the atria, that's a lot of mucking around in the atria. When you do that, you can disrupt a lot of the electrical pathways that control the rhythm. So many of these patients, the older they get, the risk keeps going up and up and up for some pretty significant arrhythmias that can be very, very hard to control. Okay? So, the mustard and sending procedure, they're essentially the same procedure, just it varies depending on the type of material you use, and there's some other minor differences, but that's essentially the goal of them, is direct blood flow that way. Started going out of favor in the early 80s. And instead, people said, well, what if we just switch the aorta and the pulmonary artery? Now, why didn't people do that initially? And the reason is because we've got a coronary artery issue. People don't like messing around with coronary arteries. People thought that those were very, if you mess with the coronary arteries, you're asking for trouble. And, that used to be very true. You need to be very careful with them. But there were enough pioneers who were seeing the long-term outcomes. Again, this is why we follow all these people. They were seeing the long-term outcomes for the mustard and sending and saying, I think we can do better. Again, the mustard and sending, surgeons had that down pat. If they were doing it enough, once they learned it, kids were doing great in infancy and in childhood. It's when they got older, they started really having a lot of problems. And you had a gradual mortality from it. People thought, we can do better. Let's switch the arteries. Let's make the left ventricle pump to the rest of the body. Let's make the right ventricle pump to the pulmonary arteries. And so that is what we do now, and that's called the arterial switch operation. And the arterial switch is pretty much exactly, we do what it sounds like. So, oops, I can't take that one off. So for the arterial switch, though we will come and transect the aorta. Right here, we actually transect it above the coronary, so we don't move the coronaries initially. And the pulmonary artery transect here, and they swap them. So now the pulmonary is coming over here, and the aorta is coming off here. In order to do this, we do need to make sure that we have two good valves, especially we want this pulmonary artery valve to be good because we're going to ask it to be our neo-aortic valve. So we're going to cut the aorta above the level of the valve, put that over here, and use this valve with this tube and switch this over here. Good. But then we need to move the coronaries. Surgeons have become good at this. They've figured out a way where they actually don't cut the coronary, they cut out part of the aorta here where the coronary is inserting. I call it a little button. And they'll take that whole little button and move that over and sew that into the neo-aorta. Okay? In the short term, early on though, it took a while to figure out how to do this right. How are we going to do the coronaries? And the early mortality for certain surgeons and in certain centers was really, really high. We went from doing a procedure that, had about a 90% and above survival in infancy to something that had, in some places, less than 50% survival in infancy. But people persevered and persisted and figured it out. And now the arterial switch operation in infancy, the survival is about 97%. It's pretty darn good. Some places haven't had a death from DTGA in quite a while. If done right and done at a good center, outcomes can be excellent. And what are we seeing long term? We're seeing much better long-term outcomes than we used to see for the Musterton setting. So these kids are doing better long-term. They're not having the major issues. We're still following them closely. Again, as I said, this surgery became very popular in the 80s, and there are some sporadic reports of running into coronary issues long-term where the coronaries can kink or get stenotic, and sometimes, even though you evaluate them, it can still be a case of a sudden cardiac death. So that is scary, and we're figuring out ways to make sure the coronaries are good long-term. Okay, next one. All right, so we have blood coming from the SVC, IVC of the right atrium, goes into the ventricle, goes to the pulmonary arteries, gets oxygenated, comes to the pulmonary veins, to the atrium, ventricle, out the aorta, the rest of the body. No big deal, no problem, right? Well, the problem, as illustrated here, is that on this side, whereas typically our right ventricle is now our left ventricle, and on this side, whereas typically our left ventricle is actually our right ventricle. So, as I mentioned earlier, we define the left and right ventricle by their morphologic characteristics, not by their positioning. And so this is LTGA. Your ventricles go through a looping process in development, which I'm not going to get too much into, but the normal looping is D looping, and that was with the D transmission grade arteries. And in this one, we had L looping of the ventricles. So, the arteries are in kind of their natural position. So people will often call this congenitally corrected transmission grade arteries, or CCTJ. If you see that, I hate that term because I think it is very misleading. All right. The pulmonary artery, even though it's coming off in the position it should, it's coming off a bad ventricle, or not a bad ventricle, but an inappropriate ventricle. More importantly, though, the aorta is coming off an inappropriate ventricle. Long term, this right ventricle can have problems and not function so well. Now, I've mentioned a number of times, how do we pick up some of these cases? How do we find them? This child is not going to be picked up by critical congenital heart disease screening using pulse oximetry. The saturations will be completely normal. And in infancy, if all we have is that the ventricles are just swapped, this child may not be picked up at all. And I guarantee you that there are adults probably walking around today who have this lesion and just have their ventricles swapped and are yet to be detected. But, there can be some other problems with this development. Two big problems, which is really what brings them to attention. First, you can have some obstruction to the flow going out to the pulmonary artery and the aorta. These didn't necessarily develop appropriately, coming off inappropriate ventricles, and that could lead to some obstruction. And if we have that, then we'll hear a murmur and someone will check it out and realize, oh boy, those ventricles are not in the right position. Secondly, though, within the ventricles run the electrical conduction systems. And so some kids may have different arrhythmias. And when working them up for the arrhythmias, we will look to see, well, is there anything wrong in the heart which is causing the arrhythmia? And that's when we can see that the left ventricle is on the right side, the right ventricle is on the left side. So what do we do for these people? The short answer is it depends. And it is kind of case by case, but if we're going to try to get things back in order, we have some options. So remember I told you some people, will call this congenitally corrected translucent great arteries, and people will say, well, don't do anything. The blood's going the way it's supposed to go. During childhood, that's fine. That can work okay during childhood. The problem, though, is that when you get to adulthood, that right ventricle is not working so well, and that can cause a lot of issues. All right, you could say, well, why even then worry? Why don't you just deal with it when they're adults? Well, once the child gets to a certain age, that left ventricle is no longer going to be usable as a systemic ventricle. Remember, it was designed to be systemic. You can't just 20 years down the road say, all right, time for you to be our systemic ventricle. Because over time, that left ventricle is used to just pumping to the pulmonary arteries. That's what it's going to get used to doing, and it's going to get what we call deconditioned. You can try to condition it back, but that can be a tough process. And going in and doing all these things later on can have lots of challenges. But not doing anything, for a child who has no obstruction or other issues is certainly an option, and some people will go that route. This is certainly one of those cases where having good discussions so that families know what their options are and what the risks are is of paramount importance, because there's no easy answers here. Because the alternative is a very complex procedure, and that procedure is called the double switch procedure. So I'm not going to draw again, but remember when we had those pant legs, so the double switch is we do the mustard and sending to get the IVC and SVC flow going over to the left, and we do the arterial switch to swap the aorta and the pulmonary. That's a complex procedure and can have some issues. But when it goes well, what are we left with? We're left with blood coming from the SVC and IVC, gets baffled over into our right ventricle. So remember, we want SVC and IVC blood ending up in our right ventricle. And then, since we've done the arterial switch as well, that blood will then go to the pulmonary artery, to the lungs. That blood will then come back to the pulmonary veins, can't go into that right ventricle because that baffle's there, so it'll work its way around and get to the left ventricle. Great. Blood coming back from the lungs ends up in the left ventricle. That's what we want. And then because the arterial switch has also been done, that blood will go from the left ventricle to the aorta out to the rest of the body. So we now have blood going into all the chambers we want it to go into in the direction that we want it to go into. So when this works well, it's a good thing. It works well. But you can still have those same complications that I talked earlier about with the mustard and sending, notably a lot of the arrhythmias and mucking around inside the atrium there. So that's why some people will say, hey, I think there's too much risk there. I'd rather live with what I got, live with that right ventricle being systemic ventricle. And there's still debate as to which one we should do, when we should do it, and why we should do them. Okay, moving on. Following the blood, we have blood going SVC to RA, IVC to RA, the right atrium, out to the right ventricle. We got a big hole here. Blood goes out this. What is that? It's not an aorta, and it's not a pulmonary artery, because these two are combining. You have one big outflow tract. Well, this is truncus arteriosus. And you may also see this term called sometimes persistent truncus arteriosus. And that's because in development, all babies have truncus arteriosus. This starts as one big tube coming out from the body and then splits into an aorta and a pulmonary artery. And so persistent truncus arteriosus is essentially a failure of that split to happen. Okay? So blood in the right ventricle and the left ventricle are both going to go out this truncus, and then some blood's going to go out the aorta, some blood's going to go out the pulmonary artery. Okay? This one is one that can often be picked up prenatally because there's only one true outflow tract coming, and there's a large VSD opening here between the ventricles. So it's typically can be picked up by prenatal ultrasound. But for those who escape prenatal detection, they may or may not have a murmur, actually. This is wide open, you're not going to hear a murmur. If there's no obstruction here, you're not going to hear a murmur. So they would be picked up due to either appearing cyanotic, absent respiratory distress, or if they're doing okay, will be picked up on pulse oximetry screening. The surgery for this one is pretty straightforward. Again, the surgeons will come in and first close this VSD. So we got to close that here. And then they will transect the pulmonary artery here so that this outflow is just going to be for the left ventricle. So we're going to use what's native there for the left ventricle, and that's going to go out the aorta. And then we'll come and we'll put a tube to go from the right ventricle up to the pulmonary artery. All right, new conduit there. Long term, these kids can have the same issues as tetralogy flow. And if you look at it, the surgery is very similar. Closing a VSD patch, making sure we have some sort of outflow going from the RV to the pulmonary arteries. They typically do not have a valve when they're getting up to the pulmonary artery, or at least if it's a valve conduit, something that's not going to last them long term. And so as they get closer to adolescence, then similarly, we need to go in and put a functioning valve into this conduit that's going from the right ventricle to the pulmonary artery. And sometimes this conduit gets nosed, and maybe even need to replace the whole conduit. So these kids will often go the surgical route for those reasons. Okay, couple more. Okay, so here let's follow the blood again. We've got blood coming from the SVC, IVC to the right atrium, going through, that's not a tricuspid valve. Okay, goes to either the ventricles. Let's look at blood coming back from the lungs. Pulmonary veins, left atrium, mitral, nope, not a mitral valve. Again, there's one big valve here. So what is this? This is atrioventricular canal defect. So just like the persistent truncus arteriosus, we all start and have one big AV canal, but for whatever reason, this does not appropriately split into two. You may also see this called as one of the endocardial cushion defects. Endocardial meaning inside the heart, cushion, that's this area, defect. Okay, so how will these children present? Well, first of all, many will be diagnosed prenatally. They can be found on prenatal ultrasound because there's just one big valve in the heart. And there's a VSD, often typically an atrial component as well. So you can usually see this prenatally. If not, it can be detected postnatally. Sometimes they'll have a murmur, but often not. Sometimes they'll have low oxygen level when we picked up by screening, but often they won't. Often there's enough what we call streaming of the blood, that the blood from the right atrium goes to the right ventricle and goes out the pulmonary artery, because everything else is in its natural positions. There's often enough streaming such that we don't have low enough oxygen levels to pick this up, but sometimes we still can. So what is the surgery for this? The surgery for this is, we've got the framework there, we just now need to make the separation. So separate the valves, close any atrial components that you have, and there's more components of this valve that you're not seeing. The surgeons are trying to split things up enough that you can get good flow from the IVC and SVC to go through the right side of that valve and have a right-sided AV valve to the right ventricle, out to the pulmonary artery. And then blood will come back from the lungs to the pulmonary veins, left atrium, go through the left-sided valve to the left ventricle. There are many different types of techniques to do this, different patches the surgeons can use, but they're all essentially the same in just trying to separate the two circulations so they can be truly in series and not mixing. The biggest complications and problems with this procedure are kind of just making sure that the valves are neither too tight nor too loose. If they're too tight, that can cause, that's what we call stenosis of the AV valves. That can cause backup of blood. If it's too tight on the left, you get backup of blood in the lungs. You can have problems there. Too tight on the right, you can get backup of blood into the liver and have lots of problems there. Similarly, if it's too loose, blood can get through the valves, but then they start coming back as well again, and you can have those same problems. You can get too much blood, cause dilation of the chambers, and you'll get blood backing up into the lungs or into the liver. So when these kids, have their operation, we're okay with them being a little bit too tight, as long as they're not way too tight, because the alternative sometimes is being too loose. So it is a balance that the surgeons are trying to accomplish here. We do need to follow these kids lifelong to watch for the development of that stenosis of regurgitation, because it can worsen over time, and also for arrhythmias that can arise and for overall function, because we are doing some intricate procedures inside the heart there. All right, following the blood again, we got blood coming from the SVC, IVC of the right atrium, going to the right ventricle, pulmonary arteries, out to the lungs, come back to the pulmonary vein, and whoa, these pulmonary veins are not connecting to the left atrium. All right, so these veins have to find a way to get back to the heart. So this is what we call total anomalous pulmonary venous return. And in total anomalous pulmonary venous return, we have all of our pulmonary veins not going directly back to the left atrium the way we want them to. In partial, you can just have one or more going back, and those can be very hard to pick up, and there are certainly probably people walking around now who have that and don't know that they have one of their pulmonary veins going the wrong area. But total veins can be a problem. So in total anomalous pulmonary venous return, the blood coming back from the lungs needs to find a way to get back to the heart. And in utero, there are lots of different vessels that we actually have that regress over time as other things develop, and some of them don't regress. And it depends on what persists or what's created, which will tell us how the blood's going to get back. Sometimes the blood can connect up with the SVC here. Sometimes the veins will have a confluence and there'll be a vein going north to get to kind of the innominate vein, and it'll connect up in the neck area. Sometimes the veins will connect up into the coronary sinus, just in the heart, and then they'll empty into the right atrium there. Sometimes the veins, they'll find a vein that's heading south, and it'll go south and hook up with the IVC down here and head up to the right atrium. So when we see that something's not connecting there, that's just part of the investigation. We need to figure out where exactly are they connecting and how are they getting back to the heart. Okay. How do these kids present? It is a very astute and superb sonographer who can pick this up prenatally. It is extremely hard to see. If you recall, in prenatal development, there's not that much blood going to the lungs in the first place, because that's not where oxygenation happens. So if there's not that much blood going to the lungs, there's not that much blood coming back from the lungs. And so if there's not a whole lot of blood coming back from the lungs, it's hard to see that those pulmonary veins are going the wrong way. It's not standard procedure to be able to identify the pulmonary veins on a prenatal echocardiogram. It is extremely difficult, and even trained cardiac sonographers have a very hard time doing it sometimes. Prenatally, it can be a challenge. Postnatally, what about examination? Well, there's no obstruction usually within the heart or flow going out, so they typically will not have a murmur. They can look pretty okay. So these kids are often the poster child for critical congenital heart disease screening, and many of the cases picked up of screening through pulse oximetry are cases such as this of total anomalous pulmonary venous return, because they need to have some sort of mixing lesion, and as such they will have low oxygen level. Because the blood, the total veins, wherever they insert, whether it be the IVC, the IVC or the SVC or somewhere, they're going to mix with all that other deoxygenated blood by the time they're in the right atrium. Some of the blood will need to go across to the left atrium in order to get out the left ventricle and the aorta, and then some will go to the right ventricle to get even further oxygenated. The surgery for this, when do we do the surgery? Technically, if there's balance flow and there's no obstruction to those veins coming back, some people would argue waiting till they're bigger. Surgical techniques are advanced enough now, though, that once we see it, we pretty much take care of it. We don't take the risk of having anything develop later on or having any problems. So if we pick it up in the newborn period, we'll usually fix it in the newborn period. Some kids can present later. That used to be more often the case before the era of CCHD screening. Now, most are pretty much picked up. And what we'll do is essentially just, these veins typically are trying to get back to the left atrium and have some confluence and then take a detour. We'll just try to hook them up to the left atrium. There are different paths to do that. It's individualized for each kid depending on how the veins are, what their caliber is, how close they are to the left atrium. But the goal is to hook up those pulmonary veins to the left atrium. Problems long term, they can develop some stenosis or narrowing where those surgical sites were, or if the veins didn't develop properly, they may not grow properly even afterwards. So we need to watch for pulmonary vein stenosis there or some obstruction to flow. But if done well, these kids, some of them will never need another procedure and they'll do just fine and can just be followed long term, but can do very well long term with no restrictions. All right, our last defect that we're going to cover today. We have blood coming from SVC into the right atrium, IVC right atrium, and we have a ginormous right atrium. Our tricuspid valve is way down here instead of up here. It's way down here into the right ventricle. And so this is Epstein anomaly. So an Epstein anomaly, this tricuspid valve is apically displaced, means going towards the apex of the heart down here, such that the right ventricle, like the true portion of the ventricle, is very small. This thing often does not function well, this valve, and the right atrium gets huge. Typically, on a chest x-ray, the whole heart should take up less than half of the chest, half the width of the chest. In Epstein's anomaly, it is not uncommon for the right atrium alone pretty much to take up almost the entire chest, the entire width of the chest. It gets huge. That can lead to problems with flow. If this doesn't work well, there might not be good forward flow going to the pulmonary artery. A lot of the flow can come backwards instead. You don't get good oxygenation that way if you're not getting good flow, blood going the direction you want, because there's so much coming back. It can also lead to lots of arrhythmias. Again, this is a spectrum. Some kids are very mild cases of this, and yes, there may be some people walking around who have this who don't know it. Other cases are much more severe and need intervention early on. The intervention that we do, again, is to try to use the valve that we can to get this to work. In rare cases, we'll have to replace the valve, but we're really just trying to get blood to want to go forward through a competent valve to this right ventricle. In some cases, the right ventricle, if it's really small and we can't use it at all, we could send this child down the single ventricle pathway, although we'd really like to try to use the right ventricle if we can. So that concludes all of the defects that we're going to cover. You should take away, though, that these congenital heart defects are a very heterogeneous group. I've tried to give you kind of the highlights of many of the common and most critical defects, but every child can be different, and there can be different associations and different things we're looking for. So don't think that any two kids are exactly the same just because they have the same defect classification. And when you're looking at these, if you're someone who's classifying these, just define and list what defects you're evaluating. What do you see? People can try to put it all together. And especially in this era of screening, what kids are we going to pick up? What are we not? Well, that all depends on the oxygen level. And the oxygen level, we're only checking the oxygen level usually in the right arm and one of the feet, so 2 parts of coming off the aorta. So we're just checking aortic oxygen level. And that oxygen level is going to depend on the degree of pulmonary blood flow compared to the amount of systemic blood flow. And the long-term goal in all of these kids is to get the appropriate balance of that. Okay? So thank you very much. It's been my pleasure to go through this with you, and I hope you come away with this learning some more about congenital heart defects. Thank you.